Hi, everyone. Welcome to Perfusion Musings, the podcast from Envello Medical, where we're diving into the science of perfusion, oximetry, and the future of cardiovascular care. I'm Casey Bowell, the CEO here at Envello Medical.
I'm Dan Rodenhaver. I'm the Chief Commercial Officer at Envello Medical. Today, we are joined by Dr. Anuradha Lala, who is the Associate Professor of Cardiology and Population Health Science and the Program Director of the Advanced Heart Failure and Transplant Fellowship at Mount Sinai in New York, also co-editor of the Journal of Cardiac Failure. Dr. Lala, great to see you again. Thanks for joining us.
Thanks so much, Casey and Dan, for having me.
We've been following your literature for a while and following your presence at the conferences, and some of the work that you've brought up is really interesting to the podcast, in particular as it relates to pre-shock. We know you've been publishing in the space of pre-shock and the role of the microvasculature in the evolution of pre-shock. Can you talk a little bit more about microvascular perfusion and its dysregulation and how that relates to the onset of shock?
Yeah, it's such a complicated yet important question, right? I think microvascular dysfunction is sort of a signal of impaired perfusion. I think we might agree with that. I think we all know that the smaller the vessels, the more vulnerable they are to injury and to lack of flow or perfusion. And so they're almost like a physiologic kind of harbinger for overt deprivation of perfusion, right? Before the lactate rises, before the blood pressure drops, before organ dysfunction kind of manifests. And so I think if we could better capture microvascular dysfunction as it relates to perfusion, we could sort of detect veering vehicles before they fall off the cliff, so to speak. And so you're kind of touching on this pre-shock phenotype paper that we put together with the Heart Failure Collaboratory that was led by my dear friend Vanessa Bloomer and others. And I think what I really like, and this for me at least stemmed off of another paper we wrote on acute decompensated heart failure, was this appreciation of how it all exists across a continuum, right? We're so used to wanting to put patients into buckets. Okay, this is a shock patient, this is a heart failure patient, this is an outpatient, this is an inpatient. And in reality, I truly believe, and I think most would agree, that heart failure exists across a continuum. You know, we're learning now on the prevention angle that it's really cardiometabolic health that precedes, or the derangement of that precedes, the development of heart failure in its various forms. And then you've got the more sort of acute development of congestion, abnormalities in perfusion that can present themselves in the acute decompensated state that exist across a continuum with pre-shock into shock. And so you could argue Sky Stage B is a little bit like pre-shock, et cetera. Again, I think that that's a little bit more semantics, and those are important when you want to study things and follow outcomes of particular patients. But the more we start to appreciate people along a continuum, I think the more ready we'll be to act appropriately in a timely fashion.
I think that's great. I think it also clearly ties in with your other recent work on myocardial recovery and how maybe we should change the way of, and it's not for me to make the decision of what we call it, but changing it from heart failure, maybe borrowing more of, I think, some of the European language of cardiac insufficiency, and describing recovery as a process. Like the period of being sick isn't necessarily the end. This isn't that's not the only way out. There are ways in which you can recover. So when you're looking for this pre-shock, there are a whole lot of tools that we have available. There's also a lot of clinical insight. Capillary refill can tell us a little bit more about microvascular state. How is it that you think the clinical community is addressing this intuition that's growing? How do you think they're approaching pre-shock? What signs might show an experienced clinician that a patient might look a little shocky?
I love what you said of thinking of recovery as a lifelong dynamic process, you know? Again, speaking to the continuum that we just talked about, I think of recovery in that along those lines too. And that's why I think recovery is a challenging word, and we can argue about semantics, but this notion of getting better and getting worse that can happen in flux and not just kind of categorizing someone, okay, they're better, they're not, right? Like we have an editorial coming out in JCF next week So this is a little teaser.
Great to publish it.
About how there's no such word as stable when it comes to heart failure. Like we should just never use it. But yet we use it all the time, myself included. Oh, this patient's heart failure is stable. Oh, they're now stable. They're in the CCU. What does that mean? Stable in the CCU? That's crazy, right? Like, but what we're trying to do is we're trying to simplify very complex processes with respect to hemodynamics, perfusion, congestion, and say we've, transported a patient into relative stability, so to speak. So I like what you mentioned. So sorry for going a little bit off topic there, but I think that's an important comment. I think that pre-shock, or what tells you that people are a little pre-shocky, is those are the people that look fine until they aren't, right?
Right.
There are people who can be sitting on the floors who are just admitted with quote unquote acute decompensated heart failure, are here for their diuretics, but in reality, they have heart, developing pre-shock to shock, so to speak. I think, how do we detect that? Well, in the pre-shock paper, we talk about the fact that you can be underperfused in the presence of normal blood pressure. And that's sort of a relatively new concept for people to kind of embrace, right? Like, if you ask 10 people, what's one of the major signs of cardiogenic shock, a majority of them will be like hypotension, right? It's just, of course, lactate, et cetera, et cetera. But I think pre-shock really gets at some of these more subtle findings.
This is the normotensive CS that you described.
Exactly. I think that would be a specific one. And I think the future is really, can we detect absence of perfusion or compromises in perfusion in other ways? I think we're limited to some extent by the biomarkers that we have, right? We are conventionally thought altered mental status, low blood pressure, lactate, urine output, right? These are the classic markers of shock or poor perfusion, but where can we go to discover whether perfusion is an issue earlier on in the game? And I think that's where it can be a very interesting field for us to explore.
Do you think this is?
I have a lot of questions. Sorry, Dan, one last question. I have a lot of questions, but I'm going to constrain my curiosity here. I want to know, in big picture, which I don't think anybody can answer yet, where in the patient's journey do we want to figure this out? But even if we just think that they're inside the hospital and the patient comes in and they are in that acute decompensated heart failure bin, where in the hospital do you think that this is most measurable or most findable?
I think that we don't have the in-between from the CCU and the floors. When you think about the floors, that could range to patients who are on inotropes, awaiting heart transplant, LVAD, or escalation of therapy for that matter, to quote unquote run-of-the-mill, warm and wet individuals who need diuresis. And so in my mind, it would be ideal for us to have a medium, like a sort of step down type of unit, which many facilities and institutions have. We don't happen to think of it that way at our institution, but I do think that it would be nice, because oftentimes we equate illness severity and acuity with where they are, right? Immediately, it's like a word association. If we played that game, you'd say CCU, you'd say shock, right? Floors, you'll say diuretics. And so I think having that kind of step down unit where people are perhaps on inotropes, where we're sort of suspecting early shock, would be one step in the right direction.
Thank you.
Do you think, and I had a similar question about the acute care setting versus patients who are at home. Do you think that the sort of dysregulation may happen more rapidly in an acute setting because the patients are already sick, or do you think that patients are at risk if they're diagnosed heart failure patients are at risk of this at any time?
I think in reality, they're at risk of this anytime, depending on where they are on the spectrum with respect to other things like their hemodynamics, like their ejection fraction, how many times they've been hospitalized, what their comorbid conditions are, how frail or robust they are. So I think all of those things do come into play, because ultimately, a concept that really, I think, resonates with me is heart failure represents a lack of reserve, right? Such that you're not able to quote unquote bounce back in the same way. And if you didn't have heart failure, for example. And so I think that heart failure to me represents different degrees of a lack of reserve, right? And so there are these insults that may happen by virtue of, ischemia, infection, whatever the trigger is, arrhythmias. And I think that the state that you present in represents your ability to bounce back, so to speak, or your reserve, right? This is what we do. If you look back at the old studies by Weber and others, why did we do functional capacity studies to assess or to categorize patients in different stages of heart failure? It was because you were unmasking cardiovascular reserve or lack thereof, right? With functional testing. And so to me, I think keeping that kind of framework in mind is so helpful. And then I would just say, coming back to the pre-shock paper that we wrote, I think there was this concept, we talked about normotensive lack of perfusion. So that kind of is this isolated low cardiac index population, right? That may or may not have hypotension like we talked about, but then there could also be isolated hypotension. And you could be in pre-shock with that, right? Like I have patients who may be described as some of the ambulatory NYHA class 4 patients maybe a decade ago, or maybe even still now, who have a systolic blood pressure of 85, and yet you take them to the cath lab because you're desperately worried that they're, have an index of 1 and they have an index of 2.2 or 2.1. And, we could also debate on what are the categories of low perfusion versus not adequate perfusion, but we know of those individuals who are ambulatory who do have cardiac indices that are less than 2.2, right? So I think that those are people who fall into this kind of framework of considering them compromised, maybe not acutely presenting, but also probably underperfused.
Yeah.
This is very interesting. I think it also relates, your concept of having a lack of reserve. The thing that's most interesting to me here is people who are chronically lacking this reserve have developed a bunch of compensatory mechanisms.
Right.
They might be much closer to the cliff than we realize. And how do we differentiate those moderately compensated but dysregulated patients who might clinically appear like they actually aren't that sick, but if they get 1% sicker, then it's right off the cliff.
Exactly.
Those patients, it's very interesting intellectual question. I think a very challenging problem you have to.
It's such a challenging problem, right? Though it reminds me of, maybe 5 to 10 years ago, the focus, and it still is to a large extent, is like how sick is too sick, right? With the LVAD population, that was always not Metamax, but oh my goodness, I can't think of it. Roadmap study was all about, are VADs beneficial to individuals who are less sick? What is less sick? How do you define it? Okay, Intermax 5, 6, 7, great. How do we really categorize those individuals? Okay, they're the walking wounded, et cetera, et cetera, et cetera. But we're getting at the same point you just made, Casey, which is like there's no one magic switch that we all know of. If we were to know that, then we would be able to time things, come in for your VAD at this point, right? And that's the ongoing struggle, I think, for many of us.
You might have hit on it, actually. You talked about functional testing, and we're all in this talk here to talk about perfusion, and maybe we don't know what the level of perfusion should be, but we know it shouldn't go down in some circumstances. And so maybe there's a combination of functional testing specifically related to perfusion that says, I don't know, this is a lot more than we would expect. You should probably get re-escalated or re-triaged or put in a different
100%. Like for me to evaluate a patient, functional testing is an imperative, because again, I think I'm looking to uncover their lack of reserve so that I have a better understanding of what and there are people who surprise me the other way around too, where someone who could be hypotensive in the office and I'm really worried about them. I put them on a CPET and they're able to do a peak VO2 of 20 when I thought that they wouldn't be able to do more than 10, And so it tells you that individual may not meet conventional criteria for requiring advanced therapies, but boy, am I going to keep a close eye on him or her, right? obviously age adjusted, et cetera. So I think that provoking people to understand their underlying lack of reserve is a really important part of this discussion.
You referenced another paper of yours a little while ago, the myocardial recovery in the systemic context, right? Let's talk about something positive. We're getting better, right? People are working on a lot of things, and we're going to do better in the future. But what I took away from that paper was that, we're looking at length of stay. We're talking about 30-day readmission rates, 90-day readmission rates. Like, what do you think ought to be the metrics? What should we be shooting for?
Oh, you guys ask all the easy questions, huh? No, I mean, I think what I liked, you're referring to this review that we wrote, which is really kind of understanding and thinking about myocardial recovery in a systemic context. And it's interesting, right? Because it's akin to what we're also seeing on the other side of the coin, which is this cardiometabolic health derangement, and it's leading to heart failure, prevention of heart failure. But what we're increasingly recognizing, and I think that the newer medications like incretin-based therapies and others are showing us how interconnected all the systems are. And we're so sort of cardio focused, heart focused, when we know that renal function is a direct representation of cardiac function or cardiovascular function. Similarly, I think we're also understanding liver function to that extent, right? It's all connected. And so if we continue to really be so heart focused only, I think we're going to miss the boat. So I really like thinking of recovery in a more systemic context rather than just, oh, your ejection fraction got better, your hemodynamics got better, your blood pressure is higher. It's needs to be taken into context of the whole being, the whole individual. Well, there's one more point that I'd love to bring up, if that's okay, which is that it's not just about taking different organ systems into context, but it's also like, can we think about recovery just more broadly, again, along a continuum? So if I come in congested, but I'm quote unquote adequately perfused, if I have optimized my fluid status and then allowed for certain therapies to be delivered that then can keep me out of the hospital or out of the acute setting, can we think of that as this, the new universal definition of heart failure uses the word remission more so. So can we think of remission a little bit more than we think of just recovery? Recovery is a way sexier word, which is why people love it. But if we think about remission, we're still aware of the fact that we can kind of deteriorate again. Okay. And so I like, again, keeping things fluid with respect to how we approach patients and thinking of recovery not just as EF going up, but really, how is the patient doing? Are they overall better from a functional capacity, from a quality of life capacity? Are they out of the hospital? All of these different metrics that we can take into account. So a little bit more of like a holistic approach to talking about remission and recovery.
Well, so that brings up another question, like that changes how we manage patients, right, in the future. So what do you see as the future of management? How will you help provide, the same patients probably with the same knowledge base, right? They probably don't know much about heart failure till they meet you. And how do you help them post this recovery period, maintain in that recovery period?
Yeah, I think it's a complex topic, right? Because there's the ideal, and then there's the logistics of executing the ideal. Right. The ideal is that everyone has access to dietitians and cardiac rehab and better foods. I don't know if you guys just saw a food as medicine paper that was put out at the AHA. I think what's old is new again. We want these quick fixes, and we want it to be rooted in medicines and in devices. And there is so much promise in that. And if we go back to the basics, can we elevate our lifestyles to doing the things that we know actually work and allow for us to be healthier individuals? So I do think that it requires a more holistic approach. The question is how to implement the strategies and the access for us to be able to deliver those in a way that's scalable.
Yeah, it's going to be challenging for sure. This is fascinating for us. This has been a great conversation. I think we enjoy hearing from thought leaders like you in this space. We're learning a lot. As you know, you've known us for a couple of years now. You know, we didn't know much when we first met you. And so conversations like this are really helpful. We really appreciate you spending some time with us today and sharing some of your knowledge with us.
Oh my goodness. Thank you. I feel like I'm very appreciative of the opportunity. I could have been a little bit more articulate, but next time, hopefully.
It was great. It was great. Great to
We're
see
all
you.
out together. Takes a team. Thank you, Dr. Lala.
Thanks again. Appreciate it.